The broadcast is now starting. All attendees are in listen-only mode.
Good morning. Welcome to Friday Morning Medical Conference sponsored by Western Montana AHEC. I'm Dr. David Lechner. I'm the Chief Medical Officer here at Community. And we're thrilled to welcome one of our own, in many ways one of our own, Dr. Lauren Wilson, who's presenting bronchiolitis in kids safely doing less. Lauren is originally from Missoula. She's a pediatric hospitalist here with Missoula Pediatric Associates. Growing up, she received her bachelor's in mathematics and German because one degree wasn't enough from Rice University, and her MD then from McGill University in Montreal before heading to the University of Vermont for her pediatric residency and chief resident year. Prior to joining us here in Missoula, she spent 5 years in Seattle as a pediatric hospitalist there with several varied interests, including bronchiolitis, which we're going to hear about today, which is timely, skin and soft tissue infections, family-centered rounding, and high-value care, as well as medical education. And Lauren has also decided to pick up a new hobby and is now one of our hockey players for the CMC novice hockey team on Sunday night. So thank you, Lauren.
Thanks, David. I'd like to emphasize that it's very, very novice. So let me just get this microphone situated. Okay, good. Yeah. All right. Well, thanks everyone for being here. I'm here to talk about your favorite topic, bronchiolitis, with a little bit of a philosophical bent this time about also safely doing less in the context of bronchiolitis. I don't have anything to disclose. What I'm hoping to talk about is first to talk briefly about what bronchiolitis is. Some of you are intimately familiar with it and others less so. And to talk about what therapies have been used, what works, what doesn't work, and to go a little bit more in depth into some of the evidence there. I want to talk about the idea of safely doing less in relation to patient safety and talk about why bronchiolitis is a great example of the challenge to safely do less when we care for patients. And then we'll kind of bring that back to your own work area. How do I safely do less and think about other conditions where this might also be pertinent? So, we good? Okay. Okay. Sounds good. So first of all, let's talk about what is bronchiolitis, and I'll try to be loud, hopefully. That'll help. So I like to think of this, when we talk to learners, we think about illness scripts, which I think are a really useful way to quickly describe conditions and also compare and contrast conditions. And the what is for bronchiolitis can be divided up into epidemiology, where we can say bronchiolitis really affects, by definition, children under age 2. The peak incidence of bronchiolitis clinically is about 6 months. The peak incidence of hospitalization is closer to the 2 months. Those are the patients that I'm seeing more. We tend to have seasonal epidemics of bronchiolitis. In Montana, it's kind of January through April. It's earlier on the East Coast. Florida has this really long bronchiolitis season. It's a little bit dependent on where you are in the country, but we're just seeing it kind of ramp up now here. Your risk factors are risk factors for any infectious disease in childhood. So having older siblings, being in school, being in daycare. Do you guys want me to pause for a minute or? Okay, no problem. What is bronchiolitis kind of descriptively? So it's an illness characterized by upper respiratory symptoms, so rhinorrhea, congestion, coryza sometimes, cough, and then lower respiratory symptoms come after that, so increased work of breathing, tachypnea, hypoxemia. Patients can have low-grade fever. They can also have feeding difficulty, vomiting. We see that fairly frequently. And why is this happening? So pathophysiologically, what's happening is you have an infection of smaller airways in children that causes mucus production and causes airway obstruction as a result, and that's usually due to a virus. There are some reports of mycoplasma, but typically what we're seeing is RSV, usually kind of in the 70% range is caused by RSV. We're seeing more rhinovirus and enterovirus, coronavirus, metapneumovirus, pretty much anything that shows up on this big crazy respiratory viral PCR that we sometimes do can cause bronchiolitis syndrome, including influenza. So Let me see. So for the pediatricians and those who see a lot of kids in the audience, this is probably, the question is not what is bronchiolitis, but why won't it leave me alone? Because we're in the middle of it right now. But to get in a little bit more depth for those of you who don't see kids quite as often, what do children with bronchiolitis look like? So they've got those symptoms that we've talked about earlier, upper respiratory symptoms, tachypnic. We see respiratory distress in children and infants in the form of grunting, sometimes flaring of the nares. We see retraction, so subcostally, intercostally, suprasternally. We'll sometimes see babies' head bob. And on auscultation, they can sound like almost anything at all. You'll hear a prolonged expiratory phase often. You can hear wheeze. You can hear crackles, usually more coarse crackles. And the thing is, the exam's dynamic. So things move around a lot. Sometimes you'll hear something on one side, then they'll cough, it'll shift to the other. And this is just kind of mucus moving around, variations in obstruction that happen during the course of the illness. So diagnosis, this is a clinical diagnosis. I'm putting a chest x-ray up here because we have found that chest x-rays have no benefit in bronchiolitis, in routine management of bronchiolitis. I'm looking at our pediatric intensivist. If you were in the ICU, this is no longer routine management. But we find that chest x-rays lead, in fact, to antibiotic use that we consider to be unnecessary. So a lot of children will have atelectasis on x-ray. And it's difficult to tell sometimes if that's atelectasis or if it's an infiltrate. And then we start wondering, should we be treating that with antibiotics? And even the best intentioned people will end up using more antibiotics if they get an x-ray. So don't get one to begin with. Respiratory viral testing. So we have a couple of options there. A lot of places have a rapid RSV or a rapid flu test. There's also a respiratory viral PCR. This is an expensive test, somewhere in the $300 to $500 range, depending on insurance and where you are. And so we recommend that it's not done routinely because it doesn't change our management. Instances in which it could change management is if you're in the first 48 hours of illness and you're considering treating influenza. If this is a medically complex patient and you're trying to figure out, are we dealing with aspiration? Are we dealing with something other than bronchiolitis? Or for cohorting patients, which we don't do here at Community, but sometimes you would put a patient in the same room with someone with the same virus. So what happens with bronchiolitis? What are the complications? So the most important one, or the most common one, I should say, is acute otitis media. For respiratory complications, though, there is a defined risk of apnea, and that's really in children under 2 months and a term infant, or for preterm infants, they're at even higher risk. And the risk goes up to about 48 weeks of corrected gestational age. It's about 3 to 5%, depending on the study you look at. And it doesn't really matter which virus you have, but that tends to be your risk. Respiratory failure happens in somewhere around 2% of patients. So it does happen, and patients sometimes require admission to the PICU, mechanical ventilation. And mortality from bronchiolitis is, I would say, fairly low, but about 300 children die each year. There's a couple different databases that we use to look at this, the kids inpatient database, and the FIS, which is a database of freestanding children's hospitals. About 45 hospitals report to that. And they each have reported a total of about 300 deaths yearly over the last 10 years. The mortality rate's going down slightly, but not a huge amount. And most of these children who actually die with bronchiolitis are those who have complex chronic conditions, not usually previously healthy children, although that does happen occasionally. So bronchiolitis is interesting from a public health point of view, partly because it is so common. So bronchiolitis, if you exclude birth hospitalizations, is the leading cause of infant hospitalization. And hospitalizations for infants more than double during bronchiolitis season. So if you walk through our pediatric ward now, you'll see a lot of babies. So it's also the contact that most families have with the inpatient system, in that in a given year, about 3% of infants are hospitalized with bronchiolitis. So, 3% of all children are hospitalized with bronchiolitis. So families are going to be admitted for something. This is the thing that they're most likely admitted for. The hospital cost is also really high. As of about 5 years ago, which is the last time they kind of measured it and calculated it, $1.73 billion a year, and that's just inpatient. So the outpatient costs, I'm sure, are also significant. What's been happening recently as far as trends with bronchiolitis? So over the last 10 years, we've seen a slight decrease in admissions, but we've seen an increase in the complexity of the patients we've also seen an increase in mechanical ventilation and a corresponding increase in cost. So just background of why this is an important condition for us to be looking at. Okay, so now I want to shift gears. I wasn't allowed to use copyrighted photos, so you guys are going to see a lot of photos of my kids. Sorry about that. So what works and what doesn't? shifting gears on our bike to school. So which treatments have been examined for bronchiolitis? This is a long list. So all of these things have been looked at. Could they possibly help? It would be great if we had a vaccine for all of these viruses that cause bronchiolitis. We don't. So what has been looked at has been a number of symptomatic treatments, treatments that are supposed to change the course of the illness. And what's the result of all of that? Well, we can kind of sort things into what's helpful, what's controversial, and what's really not helpful or sometimes even harmful. So not surprisingly, helpful are oxygen and nasal suction. Controversial are whether nasal suction, we'll get to this a little bit later, can be non-invasive or whether you need to deeply suction someone's nares. Hypertonic saline I'd still put in the controversial category, but we'll talk about that a little bit more. And high-flow nasal cannula is kind of an emerging escalation therapy that we're using probably more than we ever intended to use. And the question is that also of benefit to patients or not? So that's something that's more an active area of study that I'm not going to talk about as much today. But not helpful is this whole list of things that we've really tried. And there's a couple of things under investigation for critically ill children like surfactant, but nothing is really shown to be the new penicillin for bronchiolitis. It doesn't really change the course of the illness significantly. So we have a guideline for that, hopefully. So the 2014 AAP guideline replaced the 2006 guideline in telling us what to do and most importantly, what not to do for bronchiolitis. It's an interesting guideline because of the 14 recommendations, about 10 of them are saying, don't do this or you don't need to do this. So the guideline tells us to don't just do something, stand there. And that's my favorite kind of guideline. So what it tells us is there's no need to trial albuterol or any bronchodilator in bronchiolitis. And that's a change from the previous guideline in 2006 where they said you can do a carefully monitored trial of albuterol. We'll get to that. It also says you don't need to give hypertonic saline, and it has this caveat that you can administer it. If you have a crystal ball and you know that patient is going to stay longer than 3 days, feel free. So we have a hard time operationalizing that, and I'll get to the reason they say that in just a moment. But it also reinforced the things that I had on that previous slide that don't work. It said, don't use chest physiotherapy, don't use antibiotics, don't use steroids, don't routinely obtain a chest x-ray. Also, don't obtain viral testing unless we fit into those caveats that I mentioned earlier. Kind of a new change that we like here is you can use NG or IV fluids. Those seem to be equivalent for hydrating children who can't maintain their own oral hydration. It also says, and we'll talk about this, clinicians may choose not to use continuous pulse oximetry. And this is kind of buried in there, but it says, there's some evidence that routine deep suctioning might not be beneficial. So we'll get to that as well. But that's what our guideline says. It's a good guideline. It was a bit controversial when it came out. But overall, it is based in evidence, and things that have come out since that guideline have seemed to reinforce what it's saying. So what I'd like to talk about is kind of what went into that a little bit and why it's so difficult to use and to not use some of these therapies. So we'll look in more depth at albuterol, at hypertonic saline, pulse oximetry, and at suctioning. So albuterol, I'm not the only one to call it this, but I think it can be called the most overused therapy in bronchiolitis. And that comes from, I think, what I'm telling you about the exam of a child with bronchiolitis. So these are children who are in respiratory distress and they're wheezing. And it's very difficult in a child who's not wheezing who's wheezing after all of the quality improvement efforts we've done with asthma, with saying, these children need bronchodilators, they need steroids, they need them quickly, to look at a child who's wheezing and not give a bronchodilator. We know that this is what children with viruses do. They wheeze. They have smaller airways. They have mucus that blocks them. And so a viral infection in a young child and even in a preschool child will often cause wheezing without meaning that they have the pathophysiology of asthma. So it's been studied in bronchiolitis for a lot of different endpoints. So clinical scores, there's a lot of clinical scores about respiratory distress. Hasn't been shown to have an effect on that. Hasn't been shown to have an effect on oxygen saturation, on the need for hospitalization if you're in the emergency room, on the length of stay, or even at home on the length of a child's illness. So those are all important endpoints, I would say, and Cochrane pretty unequivocally says that it doesn't work. As I mentioned before, in 2006, we had this recommendation that you should use a respiratory score, some sort of objective measure of how hard a child's breathing, trial albuterol, see if that score improves, and if it improves, then continue albuterol. And usually on a PRN basis, there are some studies showing that if you schedule medications, that definitely does lead to an increased length of stay, whether you're scheduling a placebo or albuterol, which was an interesting study. In 2014, they actually reapproached this and said, don't even do that. Part of the reasoning behind that is that clinical scores, although there are so many different ones out there, and they've been studied in so many different ways, haven't been shown to be predictive for severity of illness, and have other weaknesses that I won't go into here. Part of the difficulty, though, also was when you give a patient anything with bronchiolitis, their exam is so variable and changes so much over time that if you give them a placebo and you come back 15 minutes later, 30% of them are going to be better. So that hurts our ability to differentiate between those who respond to albuterol and those that don't. And so AAP's response, and this is probably the most controversial part of their guideline, was to say, don't even do it. The question becomes, then, at what point do we try albuterol? And I'd like to give you a little bit of a cautionary tale to help you with that. So first of all, we kind of went through this part, but albuterol does have some adverse effects. It can cause tachycardia. It can cause hypoxemia. It can cause patients to have tremor. So those are important adverse effects. But what about labeling? So giving someone the label of albuterol responsive, I would argue, has a pretty important impact on them. So this is what we see happen a fair amount. So they get a trial in the office or in the ED of albuterol for a viral illness that causes wheeze. The patient takes a prescription home for an albuterol nebulizer, which is not a small thing that they're lugging around with them on vacation and doing things like that. When the child starts with a cough later and starts to have what would be a typical viral URI with or without wheeze, then the nebulizer comes back out. The child gets treated with albuterol. And then, our electronic medical records start tagging them as having reactive airway disease or even having asthma. The parent starts wondering if they have asthma. And a certain number of children with viral respiratory illnesses in childhood will go on to have asthma. That is true. Their risk is not a huge amount higher than it is for all comers. So tagging these children with asthma, I say, is very premature. So this is recorded. And then parents start thinking, well, do they need an inhaler before they exercise? Do they need their nebulizer before they exercise? Can I go on vacation? I have to lug this thing with me. Those sorts of things, even though it doesn't impact every family, those do have a significant impact, and those lead to increased expenses for the family to pay for healthcare and for our system in general. So I would say that, a big part of my caution in using albuterol is this label and how it gets attached and how it gets carried with children throughout their childhood and beyond. But it does beg the question, at what point is albuterol in a wheezy toddler appropriate? I think, when we study all comers in bronchiolitis, it is not helpful. How do you differentiate those kids that, it might help? And what we typically do is we ask about, family history of atopy, strong history of atopy in first degree relatives in the child. I kind of borrow a little bit from UK guidelines that differentiate between viral wheeze and multiple trigger wheeze, so children that wheeze not just with viral infections and URIs, and trying to figure out if there's someone who's albuterol responsive. But there's significant doubt in the literature about even preschool children and not benefiting from corticosteroids, perhaps not benefiting from bronchodilators as much as the school-age children that we routinely treat for asthma. So this is a little bit of an open question. But I would say, based on these guidelines, your practice should be to not routinely use albuterol in bronchiolitis. I think that's fairly clear at this point. Atopy, so we asked about asthma. So I can't pronounce things very well. We asked about asthma, eczema, and food allergies and other allergies typically. So the allergic triad, yeah. Hypertonic saline is kind of the next topic that I wanted to talk about in a little bit more detail, just so you guys get where the recommendation's coming from. So hypertonic saline is something that we give via nebulizer. It's usually 3% saline, although they've studied 7%, 9%, all of these things have been studied. The idea is that it increases mucociliary clearance by hydrating this air fluid interface in the lungs. There are some reports that it can cause bronchospasm as an adverse event, and some studies will give it with albuterol for that reason. It seems to be a rare adverse event. But we have a number of studies back and forth about, is hypertonic saline helpful? Even in the last few years, we have studies that look at hypertonic saline not improving the respiratory distress assessment inventory and respiratory rate, not changing admission rate. This one showing a decreased admission rate with 3 doses rather than 1, but no change in length of stay or the respiratory distress score. This is probably the most commonly used score in research. We've had, this was actually an unfunded RCT that was done by Alyssa Silver looking at hypertonic saline versus normal saline, including those who had wheeze, with no difference in length of stay. And then there's a meta-analysis recently that shows, it reduces length of stay, it reduces readmission, but it was a really heterogeneous meta-analysis. So I have an interesting development. It kind of leaves clinicians hanging a little bit. What do I do with this? And what we're kind of all dressed up with nowhere to go, right? What we're doing as far as looking at this is, I think, difficult to do in real time because we have studies that are published with several years lag time and we're trying to assimilate them, and there's not necessarily a recent meta-analysis. So what I like about hypertonic saline is it introduced me to this idea of an open, a living systematic review. And so you guys can go and look at this yourselves, and they incorporate in real time new articles that come out. And it's actually really great, and they've done this for other conditions, not just hypertonic saline. But they looked at a few different endpoints with hypertonic saline. One is hospital admission risk, and essentially found, and their conclusions are written up as well, and what they conclude from this is that there is no benefit to reducing hospital admission. There's a trend towards benefit, but a lot of the studies and a lot of the better conceived studies really show no benefit in reducing hospital admission. The other important endpoint that they look for is reducing length of stay. And so this was actually divided up because there are a number of studies that are done outside this country where indications for hospitalization and length of hospitalization are different than they are in the US. Our average length of stay for bronchiolitis is in the range of 2.5 days. There are places, and a couple of these studies are Chinese, where length of stay for bronchiolitis is usually 6 or 7 days on average, which is a lot different than our situation. So they divided into those with length of stay more than 3 days and length of stay less than 3 days, and looking at hypertonic saline and whether it reduces the length of children's hospitalization, and basically concluded that it makes no difference. There's a lot of heterogeneity, and in the longer length of stay, it does seem to make a difference. In those with shorter length of stay, it does not. And this is something that continually gets updated. And just looking at this list, you're like, when are we going to stop studying hypertonic saline in small wheezy infants? It seems like there's been a lot of study on it. It's certainly not having a huge effect, I think we can conclude. But based on what the guideline says, our 2014 guideline, you can consider, if you're looking at your tarot cards and your crystal ball and you think someone's going to have a longer length of stay, you can consider giving them hypertonic saline, and that might be beneficial for the patient. But then it kind of begs the question, what's the cost as well? So there was a study that was done a couple of years ago looking at hypertonic saline use in acute bronchiolitis, and they actually did their own small RCT in the study and showed no effect on length of stay, but they based their cost effectiveness analysis on a systematic review of other studies, which they admitted were fairly heterogeneous as well, and found that you came out, and I don't know what this is in dollars, but I would assume a lot. So 7.6 billion pounds per quality adjusted life year gained. So I can think of a lot of ways to spend that money better than on hypertonic saline. So if you guys want to donate, I'll start a fund and we can fund things other than hypertonic saline for children's health. So moving on, any questions about hypertonic saline from the audience here? So pulse oximetry. This is kind of an ongoing and escalating debate among the hospitalist community about how we best use hypertonic saline in bronchiolitis. So I mentioned the hospitalization rate for bronchiolitis earlier. It has gone down a tiny, tiny bit in the last 10 years. But more interesting is what happened from the 1980s until 1996. So around 1983 is when we had the first really commercially viable pulse oximetry device that was used inpatient and outpatient, and it kind of disseminated from there. What happened to the hospitalization rate for bronchiolitis is it nearly tripled. And a lot of that is attributable, I think, and a lot of people think, to pulse oximetry being used widely and people seeing these small fluctuations in children's oxygenation when they present with bronchiolitis. There's a really interesting study done in Canada in 2014 where in an ED, they basically took pulse oximeters and they hacked them. And they made them read 3% higher than they actually were. And this was just for children with a pulse ox above 88%, just for safety reasons to get it past the IRB, they had to do that. But they made it read a little bit higher. And those who were reading higher had a lower risk of admission by 40%. No drug does that, but hacking a pulse oximeter apparently does. 40% lower risk of admission. And then looking at adverse events, they looked at, did they need any unscheduled visits? Did they present to care later? And they found that there weren't any adverse events or any, unscheduled or urgent need for care, or weren't more in that hacked group than there were in the normal pulse oximeter group. I thought that was a really interesting study and raised a lot of questions on how we use pulse oximetry and how we weigh pulse oximetry in our decision to admit. And I think, kind of a careful assessment of a child's respiratory distress and respiratory status is probably of greater value than a single number, but the number is so concrete that it's easy for us to look at that and consider that to be the most important thing. Also, I'd like to point out, and I use this in reassuring families as well when we're sending them home and their child has, short desaturations to the 80s. So the CHIME group, the CHIME study group, Children's Home Monitoring, some sort of monitoring that they do with pulse oximetry, normal infants, kind of from birth to age 6 months, they take premature infants, they take term infants and monitor them at home, and finds that episodes of intermittent hypoxemia, so desaturations to the 80s and occasionally to the 70s, are far more common than we actually know. And those happened in about two-thirds of term infants and 3/4 of preterm infants. And so the fact that we see that in the hospital when someone's convalescing from bronchiolitis is not necessarily abnormal, and it's not ever been shown that oxygen actually helps those children in any way if they're having intermittent desaturations. But it's hard because we bring someone into the hospital, we hook their child up to all of these monitors. They, have these numbers, they have beeping that is, distressing to parents, I think, as well. And we come in and we look at those monitors often, and then when we're trying to send them home, we say, oh, it doesn't matter, it's okay, that they go down a little bit. So there's a little bit of schizophrenia around that within our healthcare field as well. And I think this approach is evolving a little bit. But what we do with pulse oximetry is, there are a lot of quality improvements out there about trying to get continuous monitoring off of children a little bit sooner, thinking that, that shortens length of stay without any adverse events. And I think there's more to come on that. But it's just an interesting lesson in monitoring not being a benign thing. So moving on, I got a request specifically to talk about suctioning. This is my younger son, Oscar, getting suctioned or getting saline put in his nose to be suctioned. He was the baby model for our suctioning handout at Seattle Children's. In my defense, he did have a cold at the time, so it wasn't gratuitous. But when we suction in bronchiolitis, I talk to parents about, we can clear mucus from the nose. We can't clear mucus from the lungs. That's what they do with coughing. But it's a lot of babies, particularly babies under 6 months, as a lot of us know, are obligate nose breathers, and clearing mucus from their nose really does help them to breathe. It reduces their work of breathing. It can improve their oral intake because the eat, feed, or the suck, swallow, breathe coordination is difficult when your nose is congested. Unfortunately, though, there are not very many randomized controlled trials on suction. What's there seems to suggest that non-invasive suction is helpful, but deep suction may be harmful, and I'll tell you a little bit more about that, but I just want to show you what I mean by that first. So commonly used suction devices that we see in the hospital are this kind of suction catheter. There's a lot of different types out there, also called an NP or a nasopharyngeal catheter. And that would be considered deep suction because you put that down in the back of the nasopharynx and suck snot out. This is the bulb, the ubiquitous bulb that babies go home with from the hospital. So a lot of people have seen this before. So bulb suction. This is also used in the hospital. We call it either an olive tip or it can be called a BBB suction. This is non-invasive suction. It just goes to the nair. And this is, you guys might have heard this from families. So a nose Frida. There's a lot of other brands. So this is one thing that you see parents do. So there's a little opening here. There's a filter here. They put the opening in the baby's nose, and the parent puts their mouth on that. It sounds fairly gross, but a lot of parents swear by these. I'm not endorsing anyone above the other, but you will see this being used. And so the nose Frida, the snot sucker, the Nasa cleaner, frequent brands there. So these are suction devices you'll see a lot. I have a couple that I won't recommend to you. When I was putting together our bronchiolitis guideline, I ordered a bunch of stuff off of Amazon just to check it out. One was this vacuum-powered suction device. So my favorite brand name was the Snotterator. But if you have a home vacuum that is adjustable speed, theoretically, you could buy a suction device that you put on your vacuum and then put in your baby's nose. This is taken from the YouTube video for that. So not been studied, to my knowledge, FYI. So your patients may be using a lot of these different devices. There's also the ones that are battery powered and like play music while they're suctioning out the baby's nose, which I don't know if you can hear that above the whales, but there are a lot of different things that are used. And what's really amazing about suctioning is it's so ubiquitous, but we don't really have good studies on it at all. We see it help in infants who are obligate nose breathers. It's a mainstay of our treatment. What research there is shows that suctioning in general helps, but how best to do it is still largely an open question. So I was kind of excited to see a fairly high quality study in 2013 looking at suctioning, and what it found, it was a retrospective study, but it showed that patients who had more gaps in suctioning, like they went more than 4 hours between suction events, tended to have a longer length of stay, but also that using an nasopharyngeal catheter, so doing deep suction, was also associated with a longer length of stay. And they did make a lot of effort to control for acuity, but that is a weakness of the study, that maybe those were the sicker patients. That said, a lot of people have been working on quality improvement initiatives to decrease the use of deep suctioning for your average kind of routine bronchiolitis patient. Vanita Mittal in Texas has really eliminated deep suctioning in her hospital by making it a physician order. She had over 1,000 suction events in one bronchiolitis season and went down to 44 in the next season. They didn't see any change in their rate of PICU transfer, their rate of mechanical ventilation, or their length of stay. And she's presented that in a poster, but it's not yet published. So I think more to come on suctioning, but it's very interesting that, the one thing that we think is helpful, we just don't quite know how to do it the right, the best possible way. So I don't know if I've left you a little bit lost about what do I do now, because all of the things that we look at in bronchiolitis, we're saying this is not helpful, that's not helpful, that's not helpful. So what can we do? I'll help you get through that maze. First, I want you to read this. I think it's fascinating. This is kind of my conclusion as well. So since acute viral bronchiolitis is a self-limited disease of relatively good prognosis, the principle of premium non nocere should temper frustrated anxiety to do something, anything to relieve severe dyspnea. Simple physical exhaustion may determine the fate of an infant laboring to meet his metabolic requirements for oxygen. His energy should not be frittered away by the annoyance of unnecessary or futile medications and procedures. Do you guys know when this was written? 1965. Not that long ago, but I mean, we've gone through a lot of studying since then. Yeah, they wrote much more beautifully at that point. But we've gone through a lot of studies since then, and we've kind of come full circle to this at the same time. We do have now modern intensive care, which for those few infants who develop respiratory failure has been decisive in how they do. But as far as what we do up until we get to that point, nothing's really changed. So we can run frolicking through the fields and just say we're not doing anything, or we have to find some way to make this this sort of do nothing into a positive thing that clinicians can take and work with. And so my work when I was at Seattle Children's, and we've done some of this here at Community Medical Center, is to make bronchiolitis into a fairly standardized pathway that we follow for all comers. And then there are, of course, no pathway can encompass every child who presents. There are, of course, exceptions, children who are more ill, but our standard approach to bronchiolitis should be the same. And so this is a somewhat complicated pathway. It is available online as well, in a newer version than the one that I finished there. It is based on evidence review. And the important thing is, guidelines are guidelines, and that's great, but a pathway tells you what do I do at each step of this process, and that is in some ways more helpful for clinicians and nurse and doctor behavior than having a guideline that gives you 14 recommendations. So we developed that, and while I was there, this is FIS, so all of the freestanding children's hospitals, so 45 different children's hospitals who report data versus our data in Seattle. we track a number of quality measures for bronchiolitis that show therapies that really are not recommended. And so we had some significant improvements in using our clinical pathway and not doing therapies that are not recommended. So length of stay was a little bit less than average. Bronchodilator use, you guys can read that. We were really working on reducing chest x-ray use and got partway there. And so that was, I think, significant progress. Our charges were still higher, I think, to do with the area in the Pacific Northwest. But we had a lot of success in really getting clinicians to not do things that are not recommended. Part of what I think is helpful is to have a real positive approach to what we can do for bronchiolitis. And it's not, we can't do anything, nothing works, go home and have fun. But it's, okay, this is a viral illness. It produces mucus in your lower respiratory tract, in your nose. It's treated by hydration and suction, and teaching families, this is what's going on, teaching them what to look for. These are the signs of respiratory distress I'm seeing in your child right now. I would currently classify them as mild. These are things I would look for if it got worse. Teaching families how to suction and having them show us how to suction. I've had people squeeze bulb suctions into the nose before. I've seen nods, other of you have seen that as well. And when to suction, really suction children before they feed. If you see this distress that I just taught you about, it's worsening. We do have, there are a lot of parents who will go after every booger every 5 minutes. So you have to balance those with the ones who will just ignore. But, it helps to get people on the same page. Talk to parents about how to hydrate a baby, frequent feeds, feed them whenever they're awake and calm. To know, because a lot of people come back and say it's not gone, know that this is going to last up to 4 weeks, especially the cough part. And importantly, they're increasing studies on the dangers of over-the-counter medications for cough and cold for children. So avoid that. Please avoid exposure to environmental tobacco smoke. So this was our positive script, and we taught all of the ED nurses as well as the peds nurses to follow this and teaching about bronchiolitis. And I think this helped us as clinicians as much as it helps the family, knowing that there is something that we can do for these people, and it is all of this. We might not be giving them a medication or anything that requires a prescription, but we're giving them the power of knowledge and what to do about it. So we learned a lot of lessons in doing this. There are a lot of pressures out there from various sources, from families, from other clinicians to use therapies that may not be evidence-based. We as a group seem to think that the harm of not doing something is somehow worse than doing something and having an adverse event just because, oh, did you not think of doing that? It's just our mindset as clinicians sometimes. And it's hard to change culture. It does take time, but as people cycle through, it'll happen eventually. It's just frustrating at the top. And there are certain people who are eager to change, and there are certain people who really resist change. And you have different approaches to those sorts of people. And our positive script probably did more to help us feel better as clinicians than anything else. And that's something that's also been replicated in work on antibiotic stewardship, that you're not saying to patients when they come in with their acute upper respiratory infection, no, I'm not going to give you antibiotics, that you're counseling on, this is what I think you have, and this is why I think antibiotics wouldn't help you, but this supportive care would. So that was something that we learned as well. Just to shift gears for another couple minutes, I wanted to talk about the idea, and this is an idea that kind of motivated me a little bit in this work of safely doing less. And first, in one slide, I'm going to try to give you a little bit of background on patient safety. I really can't cover in one slide all of the literature and all of the work that's been done on patient safety, but just to give you a little bit of background, there's been a renewed interest in patients and harm that happens in the hospital and keeping patients safe from harm. And a lot of it started almost 20 years ago now with this IOM report that looked at the scale of medical error and harm that does happen in hospitals. And it's driven also by national patient safety goals and the Institute for Healthcare Improvement that have done a lot of work around that. There's been a focus on reducing harm, so the idea of zero harm that hospitals are striving for. And there's a lot of components of that. There's components where we need to report errors when they're made, even if they don't reach patients. We need to track those errors. We need to build a safety culture, something that we've done a lot of work on here. And then creating redundancy using reliable methods so that things aren't getting missed, accidents aren't happening, mistakes aren't getting to patients. What's not discussed as much in that is the power of doing less for our patients, diagnosing less, treating less. And There was an editorial in Pediatrics in 2011 that really struck a chord with me on that. And this is from Alan Schroeder, who's also a pediatric hospitalist. And he talks about the fact that doing less is not been a large component historically of our patient safety discussion. But the safest action is often the one that we don't take. And he says that, there are a lot of reasons for this, but part of the reason is the pressure to do more. So uncertainty is hard for us to handle. It's hard for families to handle. Sometimes our own uncertainty gets projected onto patients, and we're trying to work through that together. Sometimes families are pressuring us to do more because they're trying to get what they can from the healthcare system with, I think, the mistaken impression that that's going to make their child better or healthier. Some of it comes from colleagues or peer review. As I mentioned, if you miss something, that seems to be a worse error sometimes than doing something you maybe shouldn't have. Medical legal fears are a factor here. Sometimes it's just easier to order that test rather than to explain why you shouldn't order that test. We also see in publication bias, and I think that's been perpetuating all of this hypertonic saline, all of the many randomized controlled trials that are done. People are more likely to publish something with a positive result than a negative, and that's been well documented. Also, fee-for-service does play a role. I mean, if I admit a child with acute gastroenteritis, I know that best practice is not to check electrolytes, but I know that some of the insurance companies will look and say, well, you didn't document hyponatremia or electrolyte abnormality, and I've had denials for that. So those sorts of things don't help us with good care. And I liked his last sentence in there, or one of his last sentences in the editorial. It says, physicians are as much a product of this culture as their patients. Together, we are co-conspirators in a behavioral system that often sacrifices safety for action. So if you guys want to read something, I do think that this is an excellent editorial and encompasses a lot of what I've been thinking about, various diagnoses that we handle in the hospital. Also, safely doing less is not, an actual campaign. This is, a couple of editorials and people who've been writing about it. You guys might have heard about choosing wisely, which I think is an effort that I applaud, that started with internal medicine in 2012, and it looks at what are these tests, what are these treatments that patients and providers should question, and basically each medical society comes up with a list of things that they think should be questioned, maybe are not evidence-based and are done too often. And it's great, but the list is one thing, the behavior change is another, and I think we still have a ways to go on that. But some of the things that they look at are imaging for low back pain when you don't have any red flags, kind of in the first 6 weeks. That's something that they say shouldn't be done. Using PPIs for stress ulcer prophylaxis in patients who are hospitalized. HRT, you guys are probably familiar with as being not helpful in postmenopausal women. Antibiotics in general, antibiotic stewardship for respiratory illnesses. Elective C-section. All of these things are things that are targets of choosing wisely. So I think that this is good that the discussion is going this way, but I think we still have a ways to go. I think what we need to do is talk about safety, kind of flip the script a little bit and talk about, often we say, let's check this lab or let's do this study or let's treat this just to be safe. But I want to argue that it's often the other way around. It would be safer not to do that test or check that study or prescribe that treatment. And maybe we need to use that language as well in talking to each other and talking to patients. So for bronchiolitis, we notice it's easier to order a test sometimes than to explain why you're not doing it. And it's easier to adopt a test or a treatment that sounds really cool. And it's harder sometimes to let it go when the evidence is showing that it's not working. So these are things that are difficult, but it's probably better care. And so that's kind of our experience with bronchiolitis. If that's true of bronchiolitis, though, what else is it true of? And there's a great article published a few years ago looking at, what are possible low-hanging fruit for overdiagnosis and overtreatment. And some of these things you guys on the list might have opinions on, but I mean, ADHD, we think it's probably overdiagnosed because if children in a given grade level are, younger than their peers, they're more likely to have an ADHD diagnosis. So is that ADHD or is that normal behavior that compared to their peers looks different to people? With hyperbiliary, we haven't seen a decrease in the risk of mortality from kernicterus since the 1970s, despite a lot more screening and a lot more treatment. So are we maybe over-screening and over-treating? That's a question. I'm seeing a few nods out there. GERD in infants. So we know the natural history of reflux in infants is they spit up, and they stop spitting up usually by about 12 months. And we know that if we treat them with PPIs, then their risk of lower respiratory tract infection is higher. So are we overtreating GERD? Do we need to reframe that discussion as well? Food allergy. If you, about 17% of people will be sensitized on IgE testing to a food allergen, but only about 2% actually have a clinical allergy. And we see a lot of patients out there doing very avoidant diets for reasons of allergy, and sometimes patients who are failing to thrive because of those avoidant diets. So I would argue that there we have, a lot of overdiagnosis and potentially harm. I won't even talk about gluten because that's a totally separate topic. But likewise, aspiration in infants. So we see a lot of swallow studies being done, a lot of, that involve radiation as well. And those are sometimes, showing us that infants are aspirating. But in neurologically normal infants, the natural history of aspiration tends to be that it resolves. I'm not talking about those infants with neurologic disease, but are we maybe overdiagnosing aspiration as well? With VUR, so there's the RIVER study that came out. Infants with UTIs were backing away from doing VCUGs for a first UTI. But really any intervention for VUR, a lot of it resolves, and those interventions that we have, including prophylactic antibiotics, don't seem to actually reduce the risk of renal scarring in children with VUR. So are we perhaps overtreating that as well? From an antibiotic stewardship perspective, I think absolutely. Obstructive sleep apnea, likewise, the rates of TNA for OSA have gone up remarkably. It used to be about 15% of TNAs were done for that reason 20 years ago. Now it's 77%. And if you do sleep studies in children looking at OSA and you don't treat them and you do another sleep study 7 months later, about half will resolve their abnormalities. So the question is, who does need to be treated? And I don't know that we have a really great answer for that yet. So I would challenge you to think, in your area of expertise, what is the next bronchiolitis? What is the condition that maybe we need to back off on over-treating? And I'm sure you can come up with a couple of things if you think about that long enough. I'm looking at my family medicine colleagues here who are nodding as well. How can you safely do less? And I think the culture change is difficult, but it involves changing the narrative to say that quality and safety are really a result of sometimes doing just enough, safely doing less than you otherwise would do. Not providing interventions is sometimes a really valid and a really safe choice that we need to make. And if something doesn't seem to be of value, we need to learn to let it go and not perpetuate it. And that's difficult, I know, but it's something that I think would improve safety for our patients. So I want to say thanks. I also want to embarrass my colleagues. 2 of our pediatric hospitalists who did not know I would use this picture in a talk. But we have a great team here. That's 2 of them. And I'd be happy to take questions if anyone has any. Rob. I'll repeat your question.
I noticed that the Seattle Children's Pathway starts in the ER.
It does.
Is there anything like that for the sort of pre-hospital environment? Because I mean, you could argue that we should have the luxury of being able to, do nasal suctioning and serially re-examine children in clinic over several hours, but that's not the reality. And unfortunately, our system isn't really resources to do that. In family medicine clinics, maybe in peds clinics, you guys do it all the time, but I suspect that we're sort of taking that 10-minute snapshot to make our sort of disposition decisions. Would you advocate use of that scoring and algorithm in the clinic setting, or is there something like that in the clinic setting for bronchiolitis?
So the question is there a pathway that we can use in the clinic setting with the time constraints that we have to evaluate children for bronchiolitis? So I guess I can go back and say, admission criteria for bronchiolitis are really if you have more than, mild, if you have moderate to severe distress, if you're not maintaining hydration orally, and if you clearly need oxygen therapy. So not, just a brief desaturation, but you need oxygen. Those are children who need to be admitted, and you probably can evaluate that when you see them in clinic right off the bat. For those that are going home, I would argue that this script doesn't take very long. this is counseling that you're doing that's going to tell them when to come back and when not to come back. Importantly, it will last 4 weeks. Don't bother to come back and tell me you're still coughing. So those are things that will save you time and save families time as well. As to whether the scripts exist, yes, actually Molly Groh, one of my colleagues in Seattle, is working on some of these standardized care pathways for outpatient practices. And so if you're interested, we can connect offline and I can see if she does have one for bronchiolitis. But I know that that's kind of in a separate wheelhouse right now and it's not online. So yeah, other questions? Lori.
So it was interesting that table that you had about the different interventions, the sort of national pre-Seattle pathway and then Seattle the year afterwards.
Yeah.
For antibiotic use, it was like the same. It was like 12 and 13.
Yeah.
Were there thoughts behind that? Because so many of the other interventions went down.
Yeah, I think that I would have expected it to go down a little bit more than that because the chest x-ray percentage went down by a third. But I think what we're seeing a lot is otitis media that's getting treated because children are younger and more highly febrile, and those are children who typically get treated, even if it is probably a viral otitis media. So yeah, there's still work to be done. And sorry, the question had been, why did the antibiotic percentage not go down quite as much as the other things? I'm sorry. Other questions from anyone here?
I just have a comment. I think it's a really great presentation.
If you have a comment.
Back to kind of efforts that need to happen. It's a hot mic. Just that a great presentation that kind of goes back to the efforts that need to happen surrounding communication and framing and kind of looking at both our own expectations for how patients are personally appearing and what the clinical course they're going to take. And it oftentimes feels like a leap of faith. But so much of that, I think, can be resolved through good communication with families on what to expect, and both in a clinic setting, an ED setting, and in the hospital setting. And this is maybe yet another paradigm shift, but a positive one. And bronchiolitis, I think, has been really well studied, and people kind of nationwide have put really big efforts into kind of safely doing less. So I just want to applaud your presentation. It's great, and it's hard to do, but I think everybody's trying to do the same thing. And it's nice to have a lot of literature and kind of hear the history of it to support those efforts. And I'll pass this mic to Kim. She's got a lot of opinions.
Would anyone else like the microphone at this point? Anything from the sites? Oh, okay, I'll keep the microphone. Lori, your question.
We have that not have the decrease in the pulse oximetry less than 80 to 90 awake for the period of time. We keep them on continuous pulse oximetry, and then they sleep, and they maybe dip to 88, last a little bit longer than we think, so they get put back on oxygen. Like, what are the more recent studies? What are other institutions doing, even if it's not published, and sort of where do we need to go?
Yeah. So the question was about, how do we take that next step in discharging children from with bronchiolitis when, we have the pulse oximeter on them and we see them dip a little bit during sleep, and just, it hangs on long enough that we feel like they need to go back on oxygen, and how can we get there? What are other institutions doing? So I think the key is, there are a lot of institutions that are struggling with this in different ways. The guidelines say you may choose not to keep children on continuous pulse oximetry, and really I think the key would be once they're clinically improving. So a lot of children are hospitalized and they're still, kind of evolving, getting worse and on oxygen, and those are children who definitely need to be on a pulse oximeter, or where I think pulse oximeters can be of benefit because they are wonderful technology, despite all the trashing I've done here. But once they're clinically getting better, there might be a role for going to spot checks earlier than we are currently doing here and earlier than a lot of institutions do there. And I think we've made some progress in kind of ignoring and reassuring about the dips, but it does make families nervous to be seeing these things, these monitors beeping and us saying, oh, it's okay, it's not a big deal. And there's actually been a lot of studies about PTSD after being in the hospital, after being in the NICU. and after pertussis in particular. There are studies showing that families have disturbed sleep, they have higher stress levels. And I think that's probably also true of bronchiolitis. I'm just not aware of any studies on that. And so kind of moving towards discharge a little bit more proactively by taking the monitors off and reassuring, I think would be helpful for those families in coping after being in the hospital as well. So, yeah. Yeah. Oh goodness. I should put this question to our outpatient pediatrician back here. She's hiding. So the question was, do we see a lot of families who are using the home monitors like Owlet or other monitors? They're little like foot monitors that'll send information to your smartphone and all sorts of things. And we have encountered a few of those families. There are very few patients who we sent home from the hospital on monitoring. So our babies with tracheostomies, babies in the NICU who are having events, need to be prone, those sorts of things. But for babies, otherwise healthy babies, the recommendation is not to monitor them at home. And I would say there's significant downsides to monitoring them at home, and it's mostly disturbed parental sleep and parental anxiety and medicalization of children. And sometimes when you speak to that, families can get that and understand. And then it always comes up, but SIDS, and there hasn't been any evidence that those monitors help prevent SIDS. And I like to talk about how the guidelines for SIDS, and they were recently renewed, the AP Safe Sleep Guidelines with some additions, how, if you're doing things according to guidelines as far as creating a safe sleep environment for your child, you're reducing the risk of SIDS by 90%, by 90%. It's a rare thing. And so I don't think it's something that you should sacrifice your emotional well-being for. But we recognize that there are families who will do it, and with smartphone apps and whatnot, it is going to become more common. And I admitted a child actually recently because they were on a home monitor that was alarming, and there was really no reason to admit them otherwise. And so that is harm coming from a home monitor. So I think our idea of what to do with those needs to evolve to some extent. So, is there a question? Okay. All right. Thank you.